Welcome to this explainer. Today, we're going to act like diagnostic detectives, meticulously breaking down the complex algorithm of hyponatremia evaluation, literally point by point. If you've ever felt completely lost in the branching pathways of sodium disorders, well, you're in exactly the right place. We're going to lock down the foundational rules, explore the precise etiologies, and leave you with a rock-solid diagnostic framework.
Okay, let's dive straight into our roadmap. We're covering the basics of osmolality and core concepts, and then walking step by step through the clinical algorithm, serum osmolality, urine osmolality, and volume status, before wrapping the whole thing up with the clinical evaluation.
Starting with Section 1, the basics of sodium osmolality, we've got to establish our baseline physiological rules first.
Let's focus on the absolute red flags here, particularly the panic values dipping below 240 or shooting above 321. Normally, serum osmolality sits tightly between 282 and 295 milliosmoles per kilogram. But once you break out of that range, you enter the panic zone. The cascading consequences as osmolality increases are intense. Above 320, the patient is at a serious risk of renal failure. Push past 384, and that hyperosmolar state actually produces stupor. Break 400, and you're looking at a huge risk of generalized seizures. And if it climbs above 420, well, it's usually fatal. It really shows just how aggressively the body defends its osmolality.
Moving right along to Section 2, hyponatremia, core concepts. Let's officially define our primary suspect.
So the absolute foundational definition of hyponatremia is a serum sodium concentration below 135 milliequivalents per liter, and we classify that by severity. Mild is anything just under 135, moderate steps it down to below 130, and severe hyponatremia, which is exactly where the clinical alarm bell should be ringing at full volume, is defined as serum sodium dropping below 125. Definitely keep these thresholds in mind because they're going to dictate our urgency later on.
To properly evaluate this without missing a single thing, we rely on a rigorous 6-step clinical framework. Step 1, confirm the serum sodium is actually low. Step 2, calculate the effective serum osmolarity. 3, check the urine osmolarity. 4, assess the patient's volume status. 5, measure urinary sodium. And finally, Step 6, determine the duration of the condition. You really can't skip a step here. If you do, it leads to misdiagnosis and, honestly, potentially harmful treatments.
Section 3 dives into Step 1 of our framework, serum osmolality. This is where we separate true hyponatremia from the fakes.
The absolutely crucial point here is that we have to calculate the effective serum osmolality, or tonicity. We do this by correcting for elevated blood urea nitrogen. Why? Because urea is an ineffective osmol. It just crosses cell membranes freely and doesn't pull water with it to affect cell volume. So, our formula takes the measured osmolality and subtracts the BUN divided by 2.8. You're mostly going to use this correction when the BUN is elevated, basically stripping away the noise to see the true forces acting on those cells.
And that leads us to the first major fork in our diagnostic road. We categorize the state as hypotonic, isotonic, or hypertonic based on that effective osmolality we literally just calculated. Less than 275, we've got true hypotonic hyponatremia. Perfectly normal, between 275 and 295, that's isotonic hyponatremia. And over 295 means we're dealing with hypertonic hyponatremia.
But before we move forward, we have to rule out those fake isotonic causes, things like pseudohyponatremia, which is just a lab artifact from high lipids or proteins, or non-conductive irrigants, which you might know as TERP syndrome. We also have to rule out hypertonic causes driven by excess solutes. On the hypertonic side, the absolute most common culprit is hyperglycemia. The high sugar draws water out of the cells, which severely dilutes the blood sodium. Interestingly, mannitol therapy does the exact same thing.
Section 4 brings us to Step 2. Urine osmolality. Now it's time to check how the kidneys are actually responding.
Okay, so a urine osmolality under 100 points us strictly toward low solute intake issues. If we see this, the kidneys are actually working perfectly, but the patient is either taking in way too much water or just not enough solutes. You see this in extreme cases like a purely beer-based diet, famously known as beer potomania, or with psychogenic polydipsia, or even ecstasy use. But on the flip side, if the urine osmolality is over 100, the kidneys are holding on to water when they absolutely shouldn't be. The urine is inappropriately concentrated.
Next up, Section 5, which is Step 3 of our framework, volume status. We've got to assess the patient's overall hydration.
Let's say the patient is hypovolemic, meaning they're dry, We have to ask why. Well, if their urinary sodium is high, over 20 milliequivalents per liter, the kidneys are actively wasting salt. This points straight to direct renal salt use losses, think aggressive diuretic use, cerebral salt wasting, or Addison disease. But if the urinary sodium is low, under 10, the kidneys are desperately trying to save whatever salt they can. That means the fluid loss is happening somewhere else, like the GI tract or from excessive sweating through the skin.
Now, what if the volume status appears completely normal? In euvolemia, our primary suspects are potassium loss, hypocortisolism, or the incredibly common SIADH. Euvolemic hyponatremia is super common in neurological patients, and syndrome of inappropriate antidiuretic hormone, or SIADH, is your classic culprit here. But you've also got to keep potassium loss and secondary or tertiary hypocortisolism on your differential, because they can present identically on a basic physical exam.
I want you to really notice the literal life or death distinction here between SIADH and CSW. SIADH presents as euvolemic and is treated by restricting fluids. Cerebral salt wasting, however, features inappropriate natriuresis, basically dumping sodium, which leads to a hypovolemic state. So CSW absolutely requires volume replacement and sodium. Misdiagnosing CSW as SIADH and restricting fluids, that will profoundly dangerously worsen their volume depletion.
Finally, if the patient is hypervolemic, they're overloaded with fluid. If their urinary sodium is over 20, their glomerular filtration rate is low, which means we're thinking acute or chronic renal failure or severe hypothyroidism. But if that urinary sodium is under 10, the kidneys are holding on to sodium despite the overall fluid overload. This is the classic hallmark of edematous states like congestive heart failure or advanced cirrhosis.
All right, our final section, Section 6, Complete Evaluation and Symptoms. Because as we know, diagnosing the cause is really only half the battle. The medical literature is crystal clear on this. Standard clinical signs, things like dry mucous membranes or skin turgor, they just aren't reliable enough. They're totally insensitive. Instead, you need to rely on objective measures. If you're uncertain, it's usually safe to run a normal saline infusion test, giving 2 liters of normal saline over 24 to 48 hours. Alternatively, checking the central venous pressure strongly suggests hypovolemia if the value drops below 5 to 6 centimeters of water.
We also have to rigorously document the duration. The 48-hour mark is our definitive clinical threshold. Anything less is acute, anything more, or if you just don't know the duration, you absolutely must treat it as chronic. Why? Because after 48 hours, the brain has already begun enacting these slow, compensatory mechanisms to adapt to the lower sodium environment. Interestingly enough, out-of-hospital occurrences are usually chronic and largely asymptomatic, with just a few notable exceptions like marathon runners or MDMA users.
Notice how dramatically these symptoms scale up based on severity. In milder gradual cases, usually under 130, you see vague stuff: anorexia, a headache, difficulty concentrating, maybe some irritability, dysgeusia, or muscle weakness. But when it becomes severe, like dropping below 125, or if it drops super rapidly, the brain just cannot compensate fast enough. You start seeing neuromuscular excitability, dangerous cerebral edema, seizures, and ultimately coma or death.
So the biggest takeaway here is this massive red flag. Fixing the sodium too rapidly will cause catastrophic osmotic demyelination, literally destroying brain tissue permanently. Remember, the brain adapts to a chronic low-sodium environment by dumping its own intracellular osmoles, right? It creates this fragile new balance. If you suddenly flood the blood with sodium to fix the numbers too quickly, water rapidly shifts out of the brain cells, causing them to shrink dramatically. That's what causes osmotic demyelination, including central pontine myelinosis. You must respect the brain's slow compensatory mechanisms and correct chronic hyponatremia slowly.
Which leaves us with a pretty critical question to ponder. If our basic clinical assessments are so easily fooled, how many of these complex, seemingly asymptomatic patients are quietly walking a physiological tightrope right now? As we've seen today, hyponatremia isn't just some low number on a lab report. It's a dynamic, multi-system puzzle that demands a systematic, algorithm-driven approach to crack. By trusting the objective data over subjective clinical exams, you can be the detective who catches the critical nuances that save brain tissue and ultimately lives. Thanks for hanging out with me for this explainer. Keep questioning those lab values and never, ever skip a step in the algorithm.